Hello, everyone. My name's Kristen Mahoney, and Kara McKee and I will be presenting multiple sclerosis and scleroderma. So, the first disease that we will be presenting is multiple sclerosis, abbreviated MS. Some disease background and the definition of MS. So, MS is an acquired immune-mediated demyelinating disease of the central nervous system. And the CNS symptoms are caused by isolated inflammation, demyelination, and axonal damage. And that damage leads to nerve conduction delays, alterations, or just complete total blocks, which then gives you your CNS symptoms. And MS can be characterized by relapses and remissions.
For the pathogenesis of multiple sclerosis, new MS lesions begin with perivenular cupping by inflammatory mononuclear cells, including T cells and macrophages. They will also infiltrate the surrounding white matter. At the site of inflammation, the blood-brain barrier is disrupted. However, the vessel wall is preserved. At the leading edge of the lesions, a large number of cytotoxic CD8 cells are found. The humoral immune system is also involved, evidenced by a small number of B lymphocytes that infiltrate the nervous system. Additionally, myelin-specific autoantibodies are present on the degenerating myelin sheaths, and complement is activated. The pathologic hallmark of an MS lesion includes the sharply demarcated areas of demyelination, which is evidence of myelin degeneration that is found at the earliest time points of tissue injury. The sparing of axons is typical, but partial or total axonal destruction may occur. The surviving oligodendrocytes, or those that differentiate from precursor cells, can partially remyelinate the surviving axons, producing shadow plaques. The oligodendrocyte precursor cells are present but fail to differentiate into mature myelin-producing cells. As the lesions evolve, there are prominent astrocytic proliferation known as gliosis. Gliotic plaques have a rubbery or hardened texture, also known as sclerosis. For the neurodegeneration in multiple sclerosis, chronic active plaques are pre-existing white matter lesions that show evidence of persistent inflammation, progressive axonal loss, and gradual concentric expansion. There are also large numbers of microglial cells at the edge of enlarging lesions without blood-brain barrier disruption. These plaques can extend upward from adjacent white matter lesions or be located within the cortex underneath the pia. There is also evidence of primary injury to the cerebral cortex. Ectopic lymphoid follicles are aggregates of B, T, and plasma cells, and they are located in the superficial meninges overlying the sulci. There are also clusters in the perivascular space. These follicles are associated with underlying demyelination and neuronal loss in the cerebral cortex. They mediate subpial cortical demyelination and neurodegeneration. Axonal death results from glutamate-mediated echotoxicity, oxidative injury, iron accumulation, and/or mitochondrial failure. For relapsing MS, inflammation is associated with focal perivenular parenchymal infiltration of lymphocytes and monocytes that are associated with the blood-brain barrier disruption and active demyelination. For progressive MS, it is more diffuse and is characterized by widespread microglial activation across large areas of white matter. It is associated with reduced myelin staining and axonal injury. Activated astrocytes induced by the microglia may also contribute to tissue damage. For the physiology of multiple sclerosis, a conduction block occurs when the nerve impulse is unable to traverse the demyelinated segment. It can occur when the resting axon membrane becomes hyperpolarized due to exposure of voltage-dependent potassium channels that are exposed. This temporary conduction block often follows a demyelinating event before sodium channels redistribute along the naked axon. The redistribution also allows continuous propagation of nerve action potentials through the demyelinated segment. It may be incomplete, affecting high-frequency volleys of impulses. It can also occur with raised body temperature or metabolic alterations. Conduction slowing occurs when the demyelinated segments of the axonal membrane are reorganized to support slow nerve impulse propagation. For multiple sclerosis, there is no clear etiology. However, it is associated with factors such as biological relatives, including first-degree relatives and monozygotic twins. It is also associated with the human leukocyte antigen, or HLA, DRB11501 allele. It is associated with dysimmunity and polymorphisms, including immune-related genes, vitamin D metabolism, certain genes in the mitochondrial DNA, fibrinolysis, and CNS function and repair. Lastly, it is also associated with environmental factors such as vitamin D deficiency in higher latitudes and viral infections, including measles, distemper, coronavirus, herpes simplex virus, chlamydia, Epstein-Barr virus, and retrovirus. For the risk factors for multiple sclerosis, you will see an overlap with the etiology. The risk factors include a genetic predisposition, vitamin D deficiency, which also increases disease activity after MS begins, viral infection, cigarette smoking, Caucasians, females, first-degree relatives, twins. For instance, there is a 1 in 3 chance if an identical twin has MS, and a 1 in 15 chance if a fraternal twin has MS. And then also populations living a greater distance from the equator. For the classifications of MS, the first is the clinically isolated syndrome. It is the first isolated clinical episode with CNS symptoms. The individual has no prior history. It can be unifocal or multifocal, and the risk of converting to MS is 80 to 90%. The next is relapsing remitting MS. It is marked by clear and defined episodes of relapse and recovery. Recovery can be full or there can be residual deficits. There is no clinical progression, and it is usually the initial presentation of MS. For secondary progressive MS, it initiates with RRMS. It is followed by deterioration or progression, and the individual does not usually return to baseline. For primary progressive MS, it is marked by continued disease progression and spastic paraparesis. Plateaus and minor temporary improvements are also characteristics of this classification. Also, usually these individuals will be greater than 40 years of age. For progressive relapsing MS, it is progressive disease from the onset with clear relapse after the onset. It is continued progression of disease between the relapse. Recovery may be full or partial, and neurological status does not return to baseline. For malignant MS, it is very rapid onset and progressive deterioration. It is marked by significant disability and death within a short period of time. For benign MS, there is no deterioration after 10 years following the onset, and it is unable to predict. For the clinical manifestations of multiple sclerosis, the subjective data includes motor weakness, spasticity, or stiffness, sensory alterations of numbness, burning, tingling, tightness, and pain. An individual can have Lhermitte's sign, which is an electric shock sensation often induced by flexion or other movements of the neck. You can have brainstem symptoms including double vision, dysarthria, dysphagia, and vertigo. You can have visual deficits including field deficit, decreased acuity, impaired color perception, and pain with eye movement. Some individuals will have optic neuritis. Other subjective data include cerebellar symptoms, including gait ataxia, intention tremor, and uncoordinated movements. You can have cognitive dysfunctions, including short-term memory deficit, slowed processing, altered judgment, and difficulty with higher-level problem solving. You can have mood disorders, including depression, irritability, euphoria, and emotional lability. Anxiety and bipolar disorder is also associated with individuals with MS. You can have fatigue, such as generalized fatigue and limb fatigue. You can have sleep disorders, bladder, bowel, and sexual dysfunction, including bladder urgency, frequency, and incontinence, frequent urinary tract infections, constipation, and erectile dysfunction. Lastly, you can also have seizures. For objective data, you can have sensory tract disturbances, including decreased vibratory sense, position sense, pinprick perception, and temperature sensation. You can have reflex alterations, including abnormal deep tendon reflexes, positive Babinski sign, positive Hoffman sign, and spastic limb weakness. You can have brainstem alterations, including nystagmus, hearing loss, and tinnitus. You can have cerebellar alterations, including ataxia, tremor, and lack of coordination. You can have visual facial alterations, including optic neuritis, optic disc pallor, pupil defect, visual field defect, and trigeminal neuralgia. You can have frontal lobe disturbances, including cognitive dysfunction and emotional lability or disinhibition. For labs and diagnostics, you will want to do a complete neurological exam. The scoring tools for individuals with MS includes an expanded disability status scale, functional system score, MS quality of life inventory, MS functional composite, cognitive scales such as a simple digit modalities test, modified fatigued impact scale, and a spasticity scale such as a modified Ashworth scale. You will also want to collect a magnetic resonance imaging. The MRI may reveal white matter lesions, spinal cord lesions, T2 weighted lesions in the periventricular white matter of the brain and the spinal cord, gadolinium enhancement on T1 imaging, hypodensities on T1 imaging, and cerebral atrophy. You will also want to obtain cerebrospinal fluid analysis to rule out other diagnoses. With an elevated IgG and oligoclonal bands in the CSF but not the serum, the presence indicates MS. The absence does not rule out MS. You will also want to obtain evoked potentials, which may reveal evidence of slowed conduction or prolonged evoked response, and it can also be non-conclusive. Here are a couple of charts to illustrate the diagnostic criteria for MS. The McDonald criteria is a common criteria used. It focuses on the number of clinical attacks, the number of lesions, as well as dissemination in space and time.
So moving on to the pharmacological management of MS, the management of MS is split into different categories. So you have your treatments for acute attacks, you have your treatments for the disease itself. So you have medications that modify the biological activity of MS, and then you also have your supportive therapy, so symptomatic management essentially. So the treatment for acute attacks consists of glucocorticoids. Oftentimes, you'll start with methylpred, 500 to 1,000 milligrams per day for 3 to 5 days, and then the provider can taper or they can decide not to taper. But if the patient needs to be tapered, they'll often move on to prednisone PO, 60 to 80 milligrams, and then that's tapered off over a span of 2 weeks. The disease-modifying therapies for relapsing forms include immunomodulators and immunosuppressive agents. Immunomodulators and immunosuppressive agents can also be used for progressive MS. It's just kind of like a different combination, but some of these include monoclonal antibodies, so your rituximab, your ocrelizumab, your ofatumumab, your ublituximab, and natalizumab. And then you also have your S1 receptor modulators. So this is your fingolimod, your ozanimod, and your ponesimod. And then you can also give dimethyl fumarate, which is a Krebs cycle metabolite, and glatiramer acetate. And then you can also give interferon B or interferon beta. And then some drugs that are less commonly used include teriflunomide, cladribine, olimtuzumab, and mitoxantrone. And then we're moving on to the supportive therapy and what kind of medications can be used for symptoms. So if your patient is experiencing ataxia or tremors, you can use clonazepam, primidone, propranolol, or even Zofran. If your patient is experiencing spasticity symptoms, then you can give baclofen, diazepam, tizanidine, or dantrolene. For pain, often anticonvulsants or antidepressants are used. So some examples of anticonvulsants that are used are phenytoin, gabapentin, and then some examples of antidepressants are like your amitriptyline or venlafaxine. For bladder dysfunction, oftentimes oxybutynin is used, and then for depression, typically an SSRI will be prescribed. And then moving on to some non-pharmacological management points. I found this figure and it kind of splits everything up. So you want your care from your medical professionals. So you want to make sure that the patient is attending their wellness visits. You want the patient to have support from their personal network. So you want to assess, what their home life is like, if they have a support group or like someone to lean on through the whole process. You have some other interventions like yoga, aerobic exercise, meditation, journaling, maybe music therapy. And then again, going back to like extended resources, maybe they can be put in contact with a support group or something. So a lot of the non-pharm management has to do with cognitive therapy and physical therapy. And then just also to add on, ensuring that they have a proper diet. So eating, fruits and vegetables, grains, the right fats really helps these patients as well. So interprofessional collaboration for those with MS. So you have your neurologist. They can help diagnose the patient with MS and kind of work the patient up and provide treatment. And then you have your urologist. A lot of times patients with MS will have bladder dysfunction problems, so often a urology consult is really beneficial. And then you have speech therapy. If the patient loses their ability to speak or communicate, then speech therapy is awesome. And also, if you're concerned for aspiration when the patient eats, speech therapy can also help with that. You have your dietitian who can give the patient like diet ideas on what's good to eat, what's not good to eat, and making sure that they're staying up with their calorie requirements. A mental health provider is often beneficial. These patients, their life is disrupted and they have very little control, so often a mental health provider is helpful. And then your primary care physician, and then your physical therapist and your occupational therapist. And lastly, we'll talk about the geriatric considerations for MS. So one thing to consider is that the elderly population, they have an aging immune system. So this may make it more difficult to treat and symptoms may progress faster. They have increasing neurodegeneration. Oftentimes their brain shrinks and gets smaller, so they have a decrease in neurological reserve. And then there's a changing benefit versus risk relationship with the disease modifying therapies. As patients get older, it may not be beneficial for them to take these drugs and experience these side effects or potential side effects of these medications. And then there is an association between the elderly population and the accrual of spinal cord lesions with increasing disability progression. And then often the elderly population who have MS, they experience progressive MS, which has fewer treatment options. And now we'll be talking about scleroderma. So some disease background and the definition of scleroderma. Scleroderma causes inflammation and fibrosis in the skin and also in other areas of the body. It's an autoimmune disease that tricks the tissues into thinking that they're injured, which leads to an excess of collagen production. You have different categories of scleroderma. So you can have your localized scleroderma, which affects the skin and structures underneath the skin. And often this type of scleroderma, you'll have morphea presentation, which is essentially the skin issues will be patchy and more scattered, and then you can also have a linear presentation, so the rash or issues will be in a line. And then you can have systemic scleroderma, also known as systemic sclerosis, which can damage blood vessels and internal organs like the heart, the lungs, and the kidney. And then systemic sclerosis is split up into diffuse and limited. And diffuse has, extended skin involvement, and limited typically just has skin involvement of like your fingertips, your face, and your distal limbs.
For scleroderma, there are two primary forms. The first is localized scleroderma, such as morphea, linear scleroderma, and scleroderma and queue de sabre. The second is systemic sclerosis. You can have diffuse cutaneous or limited cutaneous. In diffuse cutaneous, there are extensive skin induration, and progressive skin disease, interstitial lung disease, and acute renal involvement may develop relatively early. In limited cutaneous, skin involvement remains confined to the fingers, distal limbs, and face. The clinical findings include calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyl, and telangiectasia. It is formally known as CREST syndrome. There is visceral organ involvement that is often insidious and benign. Digital ischemic ulcers, pulmonary arterial hypertension, hypothyroidism, Sjogren's symptoms, and primary biliary cirrhosis can occur late. Here is another illustration just demonstrating the differences between limited cutaneous and diffuse cutaneous in systemic sclerosis. The pathophysiology of scleroderma is associated with inflammation and autoimmunity. It begins when there is a vascular insult in a genetically predisposed individual. A cascade of functional and structural vascular alterations occurs. Early immune response elicits fibroblast activation and differentiation, and sustained pathologic fibrogenesis causes irreversible tissue damage, tissue ischemia, progressive fibrosis and atrophy, and ultimately causes failure of affected organs. Here is further illustration of the pathophysiology of scleroderma. It involves vascular injury, an immune system response, pro-inflammatory fibrotic signals, fibrotic cellular responses, autoantibodies, microangiopathy that ultimately cause tissue fibrosis and architectural disruption. This illustrates the cardinal pathomechanic process in scleroderma, which involves microvasculopathy, immune dysregulation, and fibrosis. The etiology of scleroderma is unknown. However, genetic susceptibility, epigenetic dysregulation, and environmental factors are thought to play a major role. Genetic susceptibility involves genes at the highly polymorphic human leukocyte antigen region, and genes involved in innate and adaptive immunity and interferon responses. Epigenetic dysregulation involves DNA methylation, histone modifications, and non-coding RNA. Environmental factors includes infectious agents such as parvovirus B19, Epstein-Barr virus, and cytomegalovirus. Microbiome involves toxic oil syndrome and eosinophilia myalgia syndrome. Occupational, dietary, lifestyle, and drug exposures involves exposure to gadolinium contrast material, particulate silica, polyvinyl chloride, epoxy resins, welding fumes, and organic solvents and aromatic hydrocarbons. Bleomycin, pentazocin, cocaine, and appetite suppressants, immune checkpoint inhibitors such as PD-1 blockers, and radiation therapy. For the risk factors for scleroderma, the prevalence rates in England, Northern Europe, and Japan are lower than in North America and Australia. Blacks have a higher age-specific incidence rate and mortality. The peak age of onset is 65 to 74 years. It occurs more often in females, and there are also genetic associations, especially with first-degree relatives. There is also an increased risk of Raynaud's phenomenon, interstitial lung disease, systemic lupus erythematosus, rheumatoid arthritis, and autoimmune thyroiditis. Genetic variants are also implicated in other autoimmune disorders such as systemic lupus erythematosus, Sjogren's syndrome, rheumatoid arthritis, multiple sclerosis, and psoriasis. For the clinical manifestations, both subjective and objective, for scleroderma, I will move by organ involvement. For extracutaneous, you can have Raynaud's phenomenon. For integumentary, you can have bilateral symmetrical skin thickening, vitiligo-like hypopigmentation in dark-skinned individuals, hair loss, decreased sweating, xerosis and pruritus, transverse creases, fixed flexion contractures or sclerodactyl, tendon fibrosis, thick ridges at the neck, mouse cop facial appearance, rhytides or microstomia. The skin becomes thin, atrophic, and tethers to the subcutaneous fat, telangiectasia, chronic ulcerations, acro-osteolysis, and dystrophic calcifications. For pulmonary, you can develop interstitial lung disease with symptoms such as exertional dyspnea, fatigue, reduced exercise tolerance, chronic dry cough, fine inspiratory crackles at the lung bases, restrictive ventilatory defect, and reduced total lung capacity and diffusing capacity. For chest radiography, you can have lower lobe subpleural reticular linear opacities or ground glass opacifications with a apicobasal gradient. High-resolution computed tomography can show mediastinal lymphadenopathy, pulmonary nodules, traction bronchiectasis, or honeycomb changes. And bronchioalveolar lavage can show inflammatory cells. You can also develop pulmonary arterial hypertension with a mean pulmonary artery pressure of 20 or greater, a pulmonary capillary wedge pressure of 15 or less, and a pulmonary vascular resistance greater than 3. You can also have reduced diffusing capacity and exertional dyspnea, reduced exercise tolerance, angina, near syncope, and symptoms of right-sided heart failure. You can also have tachypnea, loud pulmonic component of the S2, murmur, palpable right ventricular heave, elevated jugular venous pressure, and dependent edema. The pro-BNP may also be elevated. For gastrointestinal, you can have diminished oral aperture, dry mouth, periodontitis, gingivitis or swallowing difficulty. You can have reflux, dysphagia, strictures or Barrett's metaplasia. You can have gastroparesis or gastric antral vascular ectasia. You can have bacterial overgrowth or diarrhea, constipation, sigmoid volvulus, fecal incontinence, GI bleeding, and rectal prolapse. You can have pseudo-obstruction, pneumatosis intestinalis, malabsorption or colonic pseudodiverticula. You can also have sphincter incompetence, and primary biliary cirrhosis can occur, though the liver is rarely affected. The esophageal manometry may show abnormal motility. The chest CT may show dilated patulous esophagus with intraluminal air, and the fecal studies may show a reduction in protective butyrate producing bacteria. For renal, you can have accelerated hypertension, headache, blurred vision, congestive heart failure, and pulmonary edema. You can have moderate thrombocytopenia and microangiopathic hemolysis with fragmented red blood cells. The UA may show mild proteinuria, granular CAS, and microscopic hematuria. For cardiac, you can have pericarditis, pericardial effusions, constrictive pericarditis, and cardiac tamponade. You can have heart block, premature ventricular contractions, atrial fibrillation, and supraventricular tachycardia. You can have systolic or diastolic ventricular dysfunction. The tissue Doppler, echocardiography, cardiac MRI, and nuclear imaging may reveal a high prevalence of abnormal myocardial function or perfusion, and you can have an elevated pro-BNP. For musculoskeletal, you can have impaired mobility, fixed contractures, coarse leathery crepitation, tendon friction rubs, synovitis, muscle weakness, and acroosteolysis. Here is an illustration demonstrating the various manifestations of scleroderma and how it has multiple organ involvement. For laboratory studies, you will want to collect a complete blood count or CBC, a comprehensive metabolic panel or a CMP, a thyroid panel, erythrocyte sedimentation rate, anti-nuclear antibodies as listed to the right, a urinary analysis, a 24-hour urine protein or urine protein and creatinine ratio, creatinine kinase and aldolase, and a pro-BNP. Diagnostic studies include x-rays of the extremities, nail fold microscopy, electromyography or nerve conduction velocity testing, musculoskeletal ultrasound, high-resolution CT, CT non-contrast of the chest, pulmonary function tests, biopsies of the lung and muscle, electrocardiography and Holter monitoring for arrhythmias, transthoracic echocardiography, tissue Doppler echocardiography, cardiac MRI, and nuclear imaging, upper gastrointestinal endoscopy, esophageal manometry, barium studies, and a 24-hour pH probe, and finally fecal studies. Here is the classification criteria for systemic sclerosis. Patients scoring 9 or greater are classified as a definitive scleroderma diagnosis.
Now we're moving on to the management of scleroderma. The management of scleroderma is fairly extensive because it can affect several different organ systems. But typically, to start managing someone who has a diagnosis of systemic sclerosis, you want to, or even localized scleroderma, you want to establish early and accurate diagnosis. Then you want to detect and evaluate what organs are involved. And then you want to define the clinical stage and activity of the disease. And then that's when you kind of tailor the individualized therapy for each patient and what they require or what they need. And then once you start therapy, you then assess their response to it and adjust as needed. So now that we've gone over kind of how the management process works for these patients, we can go over some of the drugs that are used. So oftentimes glucocorticoids are used for these patients or for autoimmune patients when they have pain or stiffness, but I just want to note that with these patients, glucocorticoids can send someone into a renal crisis, so they should be used sparingly and only if absolutely necessary. But for the disease itself, to try to slow progression, immunosuppressive agents are often used. So you have your cyclophosphamide, you have your methotrexate, you have your mycophenolate. You can use tocilizumab, you can use rituximab, you can use IVIG or IV immunoglobulin, abatacept, which is a fusion protein that inhibits T cell co-stimulation and function. And then a lot of these patients will get interstitial lung disease, so you can use your antifibrotic therapy. So this is like your D-penicillamine or your nintedanib. And then for vascular therapy, so these patients can sometimes present with Raynaud's or sometimes the heart is affected, and so these are some of the medications that can be used. You can use amlodipine, nifedipine, diltiazem. So these medications, they help, vasodilate and open up the vessels so that the limbs can be perfused. And then you also have your prazosin, your sildenafil. You can use topical nitro, again, kind of helps with perfusion. You can use low-dose aspirin and dipyridamole, which helps avoid platelet aggregation and allows the blood to flow. For if you have a patient with Raynaud's because of systemic sclerosis and they start having some digit ischemia and ulceration, then you can use bosentan, you can use statins and antioxidants, and then if your heart is affected, you can use carvedilol to maintain myocardial perfusion. And then also if your patient goes into like an atrial tachyarrhythmia or um, needs some rate control, then you can give metoprolol. So continuing on with the pharmacological management for these patients, so sometimes these patients will have interstitial lung disease because of their systemic sclerosis, so often cyclophosphamide and mycophenolate are used to slow the progression of disease. And then you also have your antifibrotic agent again, which is the nintedanib. Sometimes these patients will have GI complications. A lot of them will have GERD or just overall discomfort. And for the GERD, you can use Reglan, you can use erythromycin or domperidone. And then if the patient is just distended and experiencing overall discomfort, it might be too much bacterial growth. So you can do a short course of antibiotics. So these would include Flagyl or rifaximin. And then if the patient is experiencing diarrhea, you can give antidiarrheal medications. And then sometimes these patients will have pulmonary arterial hypertension. So again, going back to our drugs for that, you have your bosentan, your sildenafil, riociguat, selexipag, epoprostenol, treprostinil, and then you can also give diuretics and digoxin if needed. Moving on with the pharmacological management for these patients, if your patient is in renal crisis, they will need to be hospitalized, first of all, but second of all, you want to bring down the blood pressure. So typically, you'll start with a short-acting ACE inhibitor, and then if you're unable to manage the blood pressure after that, then you can move on to an angiotensin receptor blocker or a calcium channel blocker or an endothelin 1 receptor blocker. And then you can also use prostacyclins or a direct renin inhibitor. And then sometimes these blood pressure medications will be used in conjunction with eculizumab. For management of skincare, so these skin lesions, you can use an antihistamine, or you can use short-term use of prednisone. Typically, the dose is less than 5 milligrams. Again, cyclophosphamide and methotrexate are often used for skin conditions, and then you can use hydrophilic ointments. And for musculoskeletal complications, so pain, swelling, mobility, stiffness, you can use an NSAID. Sometimes methotrexate will be used, or you can use low-dose glucocorticoids as long as it's safe to do so and absolutely necessary. So some non-pharmacological management points for these patients, going back to vascular complications. So, for example, if the patient has Raynaud's, you'll want them to dress warmly and you'll want them to avoid cold exposure to maintain perfusion. And then sometimes if these patients have the digital ischemic ulcerations, then they can get a digital sympathectomy. For interstitial lung disease, these patients would benefit from PFTs every 6 months to make sure their pulmonary function isn't declining. And sometimes these patients will receive lung transplants. Sometimes they won't be able to if they have other complications, but sometimes they're a candidate for a lung transplant. And then also if they exhibit pulmonary artery hypertension, then sometimes that will be the management. The way to manage that would be a lung transplant. For GI complications, you want to make sure the patient is keeping up with their dental care. So visits to the dentist, brushing their teeth, etc. These patients should elevate their head of bed, especially after eating. These patients should consume small, frequent meals and avoid irritants like alcohol and caffeine. And they should also avoid eating before bedtime. For renal crisis or kidney problems, blood pressure should be monitored daily to ensure that it's within normal limits. and the patient may also be a candidate for a kidney transplant. For skincare, these patients can use bath oils. Sometimes they would benefit from massages. If the patient has telangiectasia, you can use a pulsed dye laser treatment. You can also, sometimes these patients can use carbon dioxide laser treatments and extracorporeal shockwave lithotripsy, as well as high-speed microdrilling. And if your patient has, again, like the ischemic ulcerations, then often an occlusive dressing is recommended. And then for MSK or musculoskeletal complications, PTOT. So for interprofessional collaboration of patients with localized scleroderma or systemic sclerosis, I found this figure that kind of like wraps it up and explains each part pretty decently. So for the respiratory system, if they have interstitial lung disease or pneumonia or pulmonary hypertension, then a rheumatologist, pulmonologist, and then also a radiologist would be beneficial, obviously, to read the CT scans or chest x-rays or whatever it is. If the patient has musculoskeletal problems, again, rheumatologist, PTOT. If the problem's extensive and debilitating, then potentially ortho may need to get involved. For skin issues, again, rheumatology, dermatologist. Maybe the nurse has to have a special skill set in, managing the skin problems. For cardiovascular issues, cardiologist, pulmonologist, rheumatologist again. And then for any genitourinary issues, potentially an OB may be beneficial, or like a gynecologist, and then maybe a nephrologist too if the patient is in renal crisis. And then for GI symptoms and issues, again, rheumatologist, gastroenterologist, and then maybe a dietitian. And these patients may also benefit from like a mental health provider or case management to figure out what kind of needs the patients will need upon discharge. And then lastly, we have geriatric considerations for these patients. So typically the elderly population with scleroderma, they'll have more severe manifestations at an earlier stage. So the progression of their disease is much faster, and they typically receive less targeted treatment. So they have a faster progression of disease, but receive less treatment because of their age, and it becomes like a risk versus benefit discussion. And then involvement of internal organs like the heart, the kidneys, the lungs are seen more often in the elderly, and as a result, these patients often have a poorer prognosis and higher mortality rates in the elderly.
For question 1, a 28-year-old woman of Northern European descent comes to the clinic with a 2-week history of muscle weakness and blurred vision. She reports feeling fatigued and has experienced episodes of numbness in her arms over the past several months. Her family history is significant for an aunt who has multiple sclerosis. Which of the following is not considered a recognized risk factor for developing multiple sclerosis? A, female gender, B, vitamin D deficiency, C, smoking, or D, Hispanic ethnicity? The answer is D, Hispanic ethnicity. Genetic predisposition, vitamin D deficiency, viral infection, cigarette smoking, Caucasians, females, twins, and populations living a greater distance from the equator are risk factors for MS. Therefore, female gender, vitamin D deficiency, and smoking are all risk factors. For question number 2, a 35-year-old woman presents with recurrent episodes of visual disturbances and numbness in her right leg over the past year. MRI of the brain and spinal cord reveals multiple hyperintense lesions in the periventricular white matter and cervical spinal cord. According to the McDonald criteria, which of the following findings would most likely confirm a diagnosis of multiple sclerosis? A, lesions in both the brain and spinal cord with a single clinical episode. B, evidence of lesions in at least 2 different areas of the CNS and at least 2 separate clinical episodes. C, presence of oligoclonal bands in the cerebral spinal fluid. Or D, multiple periventricular lesions on MRI with a positive family history of MS. The answer is B, evidence of lesions in at least 2 different areas of the CNS in at least 2 separate clinical episodes. The McDonald criteria for diagnosing MS requires dissemination in space, demonstrated by lesions at least 2 different areas of the central nervous system, and dissemination in time, demonstrated by clinical episodes of MRI findings separated by time. For this question, the presence of hyperintense lesions in the periventricular white matter and cervical spinal cord supports dissemination in space, and the recurrent episodes of neurological symptoms demonstrates dissemination in time. For question number 3, a 45-year-old female with a 5-year history of systemic sclerosis presents with increasing shortness of breath and fatigue. Physical examination reveals bilateral inspiratory crackles and mild digital clubbing. Pulmonary function tests show a decreased diffusing capacity for carbon monoxide, or a DLCO. What is the most likely pulmonary complication associated with her systemic sclerosis? A. Pulmonary arterial hypertension, B. Interstitial lung disease, C. Pneumonia, or D. Pleural effusion. The answer is B. Interstitial lung disease. Pulmonary involvement of scleroderma can lead to interstitial lung disease. Inspiratory crackles and a decreased DLCO are clinical manifestations of interstitial lung disease.
Question 4 says a 32-year-old African American female with a known past medical history of multiple sclerosis presents to the emergency department with complaints of an acute onset of pain, gait ataxia, and tremors. What would be the appropriate initial treatment for this patient? The answer is B, methylpred 500 to 1,000 milligrams per day for 3 to 5 days. The patient is experiencing acute symptoms, and they're symptoms of multiple sclerosis, and she has a past medical history of multiple sclerosis, so this would be considered an acute attack, and methylpred is the initial treatment for an acute attack. Question 5 says your patient is extremely distressed at a worsening tightening of the skin developing around the face and hands. The patient also has epigastric pain radiating into the chest. There's no shortness of breath or hypertension. Chest x-ray is normal, and BUN and creatinine are normal. Echo shows a pulmonary artery pressure that's elevated. PFTs are planned. The patient asks about her prognosis. Which of the following represents the greatest difference between limited scleroderma and diffuse systemic sclerosis? A. Skin remains confined to fingers, face, and distal limbs. B. ILD. C. Renal involvement. Or D. Esophageal dysmotility. So the answer is A. Skin involvement remains confined to fingers, face, and distal limbs. And the rationale is that the skin involvement in limited scleroderma is localized, while the skin involvement in diffuse scleroderma is often more extensive. So you'll see it like on the trunk or thighs, in addition to the face and fingers and distal limbs.